Hi, my name is Holly Young-Reese. I am a DNP student currently enrolled in DNP 816 with Dr. Deborah Matry. I will be presenting on glycemic control in African Americans aged 65 years and older. During this presentation, I will state the problem, discuss the importance, identify the gaps in literature, and explain why this problem is important to me. I will also discuss the results of my literature review, including identify gaps in the literature and how this impacts clinical practice. Lastly, I will discuss the implication for future research and provide a brief summary. Let's talk about the problem. Research indicates that African American older adults have the highest rates of diabetes and diabetes-related complications compared to most racial and ethnic subgroups in the United States. Some researchers attribute this excessive rate of diabetes complication among African American adults to a lack of knowledge and understanding of the disease process. Research has also indicated that diabetes knowledge measures have a biomedical orientation, including knowledge of glycemic control and using diet and exercise to control blood sugars. There are no measures to assess informal knowledge that the patient obtains outside the clinical environment. The distinction between formal and informal knowledge is meaningful for cultural groups, such as African American individuals who have historically transferred knowledge about maintaining their health from other individuals that have poor lack of understanding regarding diabetes. The gaps in the literature. The literature has an abundant information on diabetes as a major public health problem in the United States, with an estimated 9.4% of African Americans affected by the disease. The literature goes on to say that racial and ethnic minorities have disproportionately higher rates of diabetes, and also indicates that there is an estimated 17.7% of African American adults having diabetes compared to other racial and ethnic groups. Moreover, relative to other groups, African Americans experience more preventable complications associated with poor glycemic control, including retinopathy, nephropathy, and cardiovascular disease. However, research lacks studies on neurocognitive functioning of African Americans regarding stress related to discrimination, disparities, and multifaceted influences on glycemic control in this population. Clinical importance. In the United States, in 2021, the United States Center for Disease Control and Prevention reported 38.1 million U.S. adults were living with diabetes, and it is estimated that an additional 8.5 million U.S. adults have undiagnosed diabetes, demonstrating the burden of disease that requires coordination of care and quality treatment. In addition to the high prevalence, the total cost of diagnosis of diabetes continues to rise. Like other chronic diseases, the burden of disease management lies heavily upon the patient and requires strict medication adherence, regular monitoring of glucose levels, intentional eating habits, and other behavioral interventions. Individuals facing socioeconomic hardships experience higher than average rates of chronic disease, with less access to evidence-based treatment. Research goes on to show that low-income patients have higher chronic disease prevalence rates, which tends to be these African American individuals. This is clinically important because African Americans with diabetes continue to have preventable diabetes-related complications despite advances in medical health care. Why? Why is this important to me as a nurse practitioner, a family nurse practitioner, is that I treat, and I educate elderly African Americans daily, in which many have low levels of education, and they trust me with their care. I stress the importance of having a A1C at goal. So improvement in glycemic control has been achieved for me by increased time during the visit, speaking slowly to these individuals, using simple language, repeating information, and sending home a visit summary. Primary care visits are typically time limited and short, with a great deal of information given, and elderly patients tend to leave without understanding. My goal is to assist with the deficits in this patient population. Literature review. Next, I would like to discuss the literature review. The first article I would like to discuss is called Diabetes, Distress, Daily Functioning, and A1C in Black individuals with diabetes and mild cognitive impairment. It was a quantitative cross-sectional randomized clinical trial study written by Barman et al. The purpose of the study was to identify associations of diabetes distress, physical functioning, and cognition with A1Cs in older Black individuals with diabetes and mild cognitive impairment. The intervention in the study was the delivery of 2 educational-based interventions delivered by an occupational therapist and a community health worker aimed at improving glycemic control in elderly individuals with mild cognitive impairment. The results of the study found that both regimen-related diabetes distress, that is how patients felt about self-management of diabetes, and self-reported functionings, were significantly associated with glycemic control amongst these Black individuals with mild cognitive impairment. That meant they had a higher A1C level. The significance of the study indicated that older Black individuals with impaired cognition is not the sole factor in poor glycemic control, and cognitive impairment in itself is not significantly associated with A1C levels. The limitations found in the study were that it was a cross-sectional study, which prevents casual inferences. Secondly, the subjects volunteered for the study, which limits generalizability, and the results cannot be applied to all diabetics. Lastly, all subjects have poor glycemic control, which it is possible that individuals with better glycemic control may have been affected differently. The second article in my literature review I would like to discuss is called Relative Contributions of Individuals' Community Health System Factors on Glycemic Control among Inner-City African Americans with type 2 diabetes. It was a quantitative cross-sectional research design looking at how health disparities disproportionately impact inner-city African Americans, and it was written by Campbell et al. The study had no interventions. This study found that several factors were significantly associated with glycemic control improvement or worsening among inner-city African Americans with type 2 diabetes. The limitations I found in this study were that it was a cross-sectional study, and therefore cannot speak to causal relationships. Secondly, the data was self-reported and may be subject to bias. Specifically, measures of neighborhood and health systems are subject to bias based on the individual's self-lived experiences. And lastly, the study was conducted among inner-city African Americans in a Midwestern city, and may not be generalizable to all inner-city environments. The third article I would like to discuss was called Social Support, Self-Efficacy, and Outcome Expectations, its impact on self-care behaviors and glycemic control in Caucasians and African Americans, adults with type 2 diabetes. It was a comparative descriptive study design. It was by Shevell and Garvin. The purpose of this study was to examine the relationship of psychosocial variables such as social support, self-efficacy, and outcome expectations to diabetes, self-care behaviors, and glycemic control in Caucasians and African American adults with type 2 diabetes. The intervention in this study compares different teaching methods of diabetes management education provided to 3 groups. The results of the study found that while demographic factors such as race and marital status may affect certain aspects of diabetes management, the complex interactions between psychosocial factors, including social support, self-efficacy, outcome expectations, self-care behaviors, and glycemic control may vary across different populations. The limitation of the study were that it was self-reported measures that was subject to bias. The sample size may limit the generalizability of the findings to other populations. And lastly, the study limited diversity when including only Caucasian and African Americans. Literature, the literature review continued on this slide was that the fourth slide was that it was a low value, called a low value glycemic outcome among older adults with diabetes cared for by primary care nurse practitioners or physicians. It was a retrospective cohort study design. It was written by Schuttner and al. Okay, the purpose of the study was to examine patients with diabetes at high risk for hypoglycemia receiving primary care between January 2010 and January 2012, comparing patient reassignments to nurse practitioners and to those reassigned to physicians after their previous physician separated from their practice in an integrated United States healthcare system. So the interventions in the study were the reassignment of patients to either a nurse practitioner or a physician for primary care. The study found that patients assigned to nurse practitioners had significantly lower rates of overall intensive glycemic control, A1Cs that were less than 7%, compared to those assigned by physicians, assigned to physicians. The limitation in the study was that it was not generalizable due to it was conducted in the Veteran Health Administration hospital healthcare system, and it may not be generalizable to other healthcare systems. And the study had multiple confounding variables that were unaccounted for despite the advanced statistical analysis. The fifth article I would like to discuss it's called Controlled Trial of Nursing Interventions to Improve Health Outcomes of Older African American Women with Type 2 Diabetes. It was a quantitative randomized controlled trial by scaling it off. The goal of this study was to teach diabetes management to improve glycemic control and therefore prevent or delay onset of complications. The interventions included education, support, lifestyle advice, and additional phone support. The results of this study were interesting in that the diabetes interventions helped older African American women improve their A1Cs levels and reduce symptoms. The interventions, which included education, support, lifestyle advice, and was effective in additional phone support. So that all helped improve their glycemic control. The limitations in the study were that it included self-reported data, which is subject to bias. Secondly, study was limited in generalizability in that it was conducted in a specific population of older African American women in a rural area. Lastly, the study was subjected to the Hathorne effect because of the awareness of being in the study may have influenced their behavior and their study outcomes. Next, I would like to discuss the gaps in the literature. So, regarding the patient population, several studies identified that stress is a related factor affecting glycemic control. However, research lacks studies on neurocognitive functioning of African Americans regarding stress related to discrimination, disparities, and a multifaceted influences on glycemic control in this patient population. I would like to see research completed on the levels of influence, such as knowledge, beliefs, attitudes, and self-care. The research also indicated to me that it was lacking in identification of physiological responses to discrimination and structural oppression, whether it was associated with worsening glycemic control in this elderly African Americans, and it needs to further studies. A second gap that I noted was the communities. Most of the literature I reviewed lacked generalizability due to the targeted samples. I would like to see further research that would explore the primary influence between community and health system factors on glycemic control. I have something. Let's go back. Wait. Why is